This is Dr. Stanley Galant, um, dictating my presentation for the upcoming meeting. I want to thank the organizers for inviting me to speak on one of my favorite topics that is related to the importance of the peripheral airways in bronchial asthma as assessed by oscillometry. My presentation will include these chapters. First of all, talk about the importance of the peripheral airways in asthma, methods to assess peripheral airways, a description of the mechanism of how oscillometry works, key elements on a proper oscillometry performance, and some of the key studies that I've been involved with regarding the value of oscillometry when identifying uncontrolled asthma, the loss of asthma control, and the use of reference values for identifying peripheral airway impairment. I'll also go through a section comparing oscillometry with the gold standard spirometry. We'll also touch on what if you added oscillometry to spirometry. Is there advantage in doing that in identifying uncontrolled asthma and exacerbations? And I'll close with the topics that are the title of my presentation, clinical characteristics which you can determine in your office, which is highly associated with peripheral airway impairment, in case you don't have the device to measure it directly. What are the peripheral airways? When we talk about the peripheral airways, we're talking about the airways, the tracheobronchial tree, distal to the 7th and 8th generation, with an intraluminal diameter of generally less than 2 millimeters. Why is it important to evaluate the peripheral airways and determine what I call peripheral airway impairment? The peripheral airways are the major sites of airway obstruction and inflammation, particularly in those with persistent asthma, both in adults and children. Peripheral airway impairment is estimated to be present in at least 50% of children and adults with persistent asthma. Peripheral airway impairment is associated with airway hyperreactivity, nocturnal asthma, future exacerbation, poor asthma control, and severe steroid-dependent asthma, as well as predicting the loss of lung function, particularly in children as they grow older. Also, I think it's the feeling of myself and other investigators who deal with children with bronchial asthma that 20 to 40% of kids with persistent asthma who don't do well, possibly based on the fact that the peripheral airways are not being attended to with medication. And that brings up the topic of targeted therapy. That is, the inhaled corticosteroids of a proper size that reach the peripheral airways. And then finally, untreated peripheral airways may result in airway remodeling with fixed airway obstruction. Now, how do we assess for peripheral airway impairment? There are many, many ways of doing it, but the focus of this presentation is on impulse oscillometry, which I feel is best suited for the office practice. What is oscillation technique? The concept of force oscillation, initially demonstrated by Dubois in Paris, is the concept of applying oscillation of sounds of pressure at the airway openings and the respiratory mechanics that then can be measured from the superimposition and external oscillation on the respiratory system during resting breathing. This complicated table, I want to illustrate just a few points that you can study the full thing later. The first is impedance. Impedance is a calculation of the total force needed to propagate a pressure wave generated from a sound source throughout the pulmonary tract. And it's really divided into resistance, RRS, which is the energy required to propagate a pressure wave through the airways that passes through the bronchial tubes and actually into the lung, and reactance, which is energy generated by the recoil or the elasticity of the lung. In this presentation, which is part of the report, we see on the top resistance, which is R, and in the bottom we see X and AX. R stands for resistance, and resistance 5 is the resistance at 5 hertz. Being lower frequency and low in energy, it can propagate through the entire airway. In contrast, R20 is the resistance at 20 hertz, which is high energy and is dampened out in the upper airway. So if one subtracts the R20 from the R5, one gets R5 minus R20, which equals the resistance in the peripheral airways. On the bottom half of the slide, we see X5, which is reactance or elasticity at 5 hertz, which is the peripheral airways. AX, which is the integrated reactance between 5 hertz and what we call the resonant frequency, which crosses the 0 axis. And we'll be talking about R5 minus R20, R5, X5, and AX primarily. With the bronchodilator, there are lots of beta receptors in the peripheral airways. We get a diminution in the resistance. You can see post-BD has a lower resistance, and we have less reactance. And you can see post-bronchodilator, we have greater elasticity rather than a stiffer lung we had before. The proper way to assess oscillometry, and this is a impulse oscillometry or IOS, is in the sitting position with the cheeks compressed, nose clips, and 30-second normal breathing trial. We'd like to get 3 adequate trials, which means a coefficient of variation of generally less than 15%. A more recent development is a portable oscillometer called the Tremaflow. And I think that is going to be used more in the future because of its portability. Now, if one were to look at the patterns of oscillometry, looking at the peripheral versus the proximal or central airway, we see first the normal resistance pattern in red, and we see the reactance normal pattern in blue. For distal obstruction, we get a much greater resistance at 5 minus 20 hertz, and that R5 minus R20 shows frequency dependence, very characteristic of peripheral airway. The greater distance difference between R5 and R20 indicates that. And also we see greater reactance in blue. If it's just proximal obstruction, we see a straight line, that is, resistance is the same at all frequency. There's no frequency dependence. In fact, it's called frequency independence. And we see no change in elasticity or reactance. Now, in the next few slides, I'm going to be sharing with you my research experience. It started in 2010 by looking at the ability of oscillometry, impulse oscillometry in this case in children, to identify children with uncontrolled asthma using asthma guideline criteria and comparing that with spirometry. I'd like to call your attention to the patient with uncontrolled asthma and the fact that the FEV1, 95% of the time, was normal in comparison to the FEF 25-75 and the FEV1-FEC ratio, which were lower. So one could have a normal FEV1 in light of uncontrolled asthma by guidelines. However, using a receiver-operator characteristic analysis, one can determine the sensitivity and specificity of different oscillometry parameters, such as R5 minus R20, X5, AX, and R5, and looking at the percent that correctly identified the uncontrolled asthma. And you can see that the percentage is extremely high. R5 minus R20 correctly identified patients with uncontrolled asthma above 80% of the time, as did AX. And looking at area under the curve greater than 0.7, in this case greater than 0.8, was also found in R5 minus R20 and in AX, with X5 being 0.8, suggesting that oscillometry was a very good tool for detecting uncontrolled asthma. Our next experiment looked at whether oscillometry could predict those children that would have an exacerbation, say 8 to 12 weeks later or on their second visit. These were patients that were well controlled at visit 1 by asthma guidelines criteria, but either had normal oscillometry or abnormal oscillometry, and then looking at the predictability. If we looked at R5, for example, and compared those children at visit 1 who had normal oscillometry with the normal R5, and compared their being controlled at visit 1 and being controlled at visit 2, compared to those kids that had abnormal baseline oscillometry and then came back uncontrolled, there were significant differences at baseline for R5, R5 minus R20, and AX. And these are all peripheral airway markers of obstruction. And so one could predict from this which kids were going to have an exacerbation at their follow-up visit. Notice R20, which is a measure of the central airways, did not distinguish this. And again, if we looked at the accuracy, we could see that R5 minus R20 was 83% accurate in predicting exacerbation, and AX was even better at 90%. So these are very good markers that could predict a future exacerbation. The next set of experiments was done more recently and published in 2020, about 7 years later. I was interested in determining whether reference equations and reference values for oscillometry could predict or identify uncontrolled asthma, as well as cut points determined by the best sensitivity and sensitivity in prior experiments, because reference values would be more generalizable. The primary goals of our study were to establish the relationship between peripheral airway impairment or obstructed peripheral airways defined by standardized iOS reference values and uncontrolled asthma. We wanted to determine whether these reference values in both Hispanics and whites would have the same response, showing cross ethnicity for these reference values, which are extremely important, And then as a secondary goal, we wanted to compare using reference equation, reference values, but those determined by receiver opera characteristics, PAA thresholds. This is an example of our results. This is looking at R5, and this is representative of all the other metrics. We could clearly discern that the 95% confidence interval for normals, well-controlled and uncontrolled, were clearly different and statistically different. This was for R5 minus R20, X5, AX and X5 show clear differences, statistically significant differences between normal patients with well-controlled asthma and uncontrolled asthma. Furthermore, we wondered whether the more peripheral airway impairment you had, would this be increase the probability of uncontrolled asthma? And you can see patients with normal peripheral airways, patients with a 1.645 standard deviations, and those that exceeded 3.5 standard deviations. And you can see the more peripheral airway disease they had, the more likely, this is 83% chance of having uncontrolled asthma. There's a direct linkage there. Furthermore, what's very exciting, patients that were well controlled, as we showed previously, could also have peripheral airway impairment. Let's say that 25 to 45%, that you would never know unless you did oscillometry, certainly was much higher in those patients who were clinically uncontrolled. And finally, we demonstrated that using reference equations from a Mexican population and a Polish population had a lot of agreeability. So the correlations were extremely high for most of the oscillometry metrics. And we concluded then that a peripheral airway impairment defined by oscillometry, not central airways, is consistently associated with the risk of uncontrolled asthma, even in those patients on step 3 or higher inhaled corticosteroids. And this was true across ethnicity. And the standardized reference values offer the clinician a readily available iOS cut points that are clinically relevant, as I said, across ethnicity. Now I'm going to run through a series of slides in which we compare oscillometry with traditional spirometry. The advantages of oscillometry are that it's effort independent, and that can be performed in children as young as 3 years old. It separately evaluates very nicely central and peripheral airways, not easily possible with spirometry. iOS is more diagnostic, identifying asthmatic children, uncontrolled asthma, loss of asthma control, exacerbation, as well as predicted loss of lung function. Now, if one compares identification of asthma control and uncontrolled asthma with oscillometry, this particular study by Cutini in Italy, you can clearly show that patients that are well controlled have statistically lower levels of R5, R20, or less obstruction in peripheral airways compared to partially controlled and uncontrolled asthma. Very similar to our data. In contrast, using the FEV1 percent predicted and looking at ACQ, a measure of asthma control, there's virtually no correlation or very little correlation. This has been found in a number of studies. However, what if you were to combine spirometry and oscillometry? Because spirometry is not going to go away. Is there an advantage? Clearly, the studies from Scotland by Chan and Bryant Whitworth, show that you can enhance identification with a larger odds ratio of uncontrolled asthma and exacerbations if you combine FEV1 and the oscillometry metrics. For example, if you combine FEV1 by himself, had a odds ratio of 3.45, and if you combine them, it's 7.41, so much higher. This applies to all the combinations. So there is an advantage of adding oscillometry to spirometry, not one or other, giving better odds ratio than either alone. And finally, what are the clinical characteristics which are associated with peripheral airway obstruction? We found certainly age was important, and this was particularly striking in the young children, had a much higher odds ratio of having peripheral airway impairment than those that were 12 and above. And we also found that obesity, a high BMI, was another factor, uncontrolled asthma, and finally, FEF 2575. Putting that all together and doing this heat type analysis, we found that in the red zone are a very high probability of having peripheral airway impairment. We found that a combination of obesity, young age, uncontrolled asthma, and also FEF 2575. However, if a patient were 4 to 7 obese and uncontrolled, the probability was above 80%. And this would be very valuable, particularly if you didn't have the oscillometer. In conclusion, we found that peripheral airway impairment associated with poor asthma control and increased exacerbation. It's the best in-office tool for identifying peripheral airway impairment. And with the establishment of validated reference values, we're able to cross ethnicity between the white and Hispanic population. The addition of oscillometry to spirometry better identifies uncontrolled asthma and exacerbations than either alone. I didn't touch on that, but I think that there are compelling data to show that extra fine or very small particle inhaled corticosteroids, such as Qvar, oral Avesco, are more effective than non-extra fine inhaled steroids, such as Flovent, for example, in improving asthma control and in reducing peripheral airway impairment. And then finally, utilizing clinical characteristics such as young age, obesity, uncontrolled asthma, as well as FEF 2575, can identify peripheral airway impairment, which is particularly useful when oscillometry is not available. Thank you.